Thank you both for your excellent presentations. You've certainly stimulated my thinking, and I assume everybody else's. I'll now open now to ask the roundtable members to state your questions. Let me ask you, if you have a question or comment, to put up your tent card so I can go around and pick people who have want to say something. If there's sufficient time, we'll open the floor for audience participation. Uh, Please use the microphone, and let me ask everybody who speaks, including the roundtable members, to state your name and your affiliation. Rima?
Rima Rudd. I'm at the Harvard School of Public Health. Those were two absolutely brilliant presentations, and I thank you. Most especially the highlight on the importance of thinking about context. And second, Ellen, I thought that I just read your paper with absolute delight. It really provided us with a very, very rich background. My only comment is that I'm asking you, unfortunately, to raise the bar, because the example that you gave, i.e. compare and contrast two different health plan options, is considered by educators and by the developers of the assessment tests to be very sophisticated tasks, well beyond basic skills. Basic skill level, and you were talking about below basic, the hierarchy of skill levels is to find one piece of information. That's the simplest task. Harder than that is to find two similar pieces of information. Harder even, and considered to be a high-level task, is to do a process like a comparison and contrast. So the example that you gave, I think the bar needs to be raised, because most people at basic level literacy would have difficulty accomplishing that task with accuracy and consistency, comparing and contrasting two bits of information. So that's the only comment, is the idea of raising the bar, but I thought that you laid out the issues and difficulties just wonderfully well. So thank you.
Yeah, thank you. Just one quick comment there. I think it depends a lot, and this is sort of how you started off your comments. I think it depends a lot on the context. It depends on whether they're simply given the information in very short form without any other information around it, as opposed to what they're going to have to do within the healthcare exchanges, which is to actually try to locate multiple pieces of information in a more complex table. So going back to Dr. Apter's hierarchy, even within what she calls a basic level of you don't call it quantitative literacy, but math skills maybe, even within that basic level, things differ quite a bit in difficulty, because it does depend on how they're given the information, for example.
In order to there we go. In order to avoid my getting in trouble by somebody saying, "Oh, you called on them first," I think I'll just kind of go around in a single direction. So I think, Patrick, you're next.
Thank you. Thank you very much for the enlightening presentation. I'm curious as to the qualitative nature of numeracy and how some patients, by the way, I'm Patrick McGarry with the American Academy of Family Physicians, and some patients distrust numbers. And so there's a real key component to that with accountants talking to you, your tax preparer, your doctor, your nurse, whomever. So do you take that into consideration, the qualitative nature of numeracy?
We take it, so I thought your question at first was going to be on qualitative research around numeracy, and we've actually done very little of that. The qualitative nature of numeracy, as I heard you describe it, comes into some of these, what we call emergent decision-based numeracy skills, because it is the case that people who are less numerate, they do tend to trust numbers less well, at least within health context. There's some data there from John Barron's lab back a bit ago. But they also, they avoid, people who are less numerate are more likely to avoid numbers, to not look at them if they're in front of them. And I think that gets at the kind of issues that you're talking about, that the sort of qualitative nature of how much do people interact with numeric information versus avoid it and interact with some other kind of information in order to make whatever judgment or decisions at hand.
if I may follow up, I mean, Mark Twain said, there's lies, damn lies, and statistics. And so I think people really do believe that. I mean, some people, I should say. And so I think it's real as far as a practitioner when discussing numbers with their patients.
I do think it depends a lot on how those numbers are presented, though. There's some evidence with like prescription drugs. If you take a look at how people respond to adverse events with prescription drugs, it's actually the case that people perceive less risk from those adverse events and they're more willing to take the drug, at least in hypothetical kinds of situations, if they're provided numbers versus they're not provided numbers. If they're told that the likelihood is 10% as opposed to its whatever that level is within the European label situation. And so, and that's true across numeracy groups. That's true for people who are more numerate, and it's still true for people who are less numerate. And so I think it does depend. It also, I think, depends on how information is communicated. If someone communicates information to me in a very complex way, and that often happens in physicians' offices, even for someone who's like myself, I'm not a physician, but I'm fairly educated within health kinds of issues. I may be less likely to trust the information simply because it goes over my head. And so why would I believe it? I didn't understand it. I don't know if the person's talking down to me. So I think some of those, again, going back to some of the context issues and the how information is presented issues, I think that makes a strong difference there.
Could I just
Sure,
say
go ahead.
one thing? I think related to that, we do have to deal with the fact that people perceive information the way they want to perceive it, or the way, I mean, just look at the discussions about global warming, and all the scientists could say one thing, but you have a lot of people who say, well, I don't think so, based on nothing, or the safety of vaccines and autism. I'm, as someone who's not a medical person who hears about this stuff, and I say, well, everybody's tested all these vaccines. There doesn't seem to be any connection between, but then yet you have a lot of people who don't want to get their kids vaccinated because of some mysterious danger they think is imminent or something. So I think that is something that people have to be aware of and think about, and realize that somebody may be responding affectively based on some emotion rather than based on the data that somebody's putting out there in front of them.
I think what you're referring to is what we often call a confirmation bias, that we pay more attention to and are more likely to believe something that fits with our current beliefs. And we often think of that in terms of narrative literacy, but obviously you're pointing out same thing is true in terms of numbers.
Could I just make one other point there real quick? There's actually an interesting thing that happens in climate change in particular. That kind of motivated cognition is actually shown more by people who are highly numerate and highly scientifically literate than the people who are less numerate and less scientifically literate. And I think the same thing is true with vaccines. I'm not positive about that. I know the data on climate change pretty well. But just back to your point, there are people who don't trust numbers, who don't trust information even within the health system. There are large cultural differences even on that. So I think that the issue you brought up is important. I just think that, I'm not trying to downplay it. What I'm saying though is that I wonder to what extent some of those issues could be alleviated in part if more careful attention was paid to information presentation.
Thank you all for the time you spent on that and for talking with us. I want to push you a little bit and ask you if you were queen for a day, each of you, and you could really lay out an opportunity with the Affordable Care Act, its timeliness, to impact patient protection and affordability of healthcare and improve the public health of America, and your zone related to numeracy, however you define it. What are the biggest opportunities that exist, and what would you do? So not the challenges. I get kind of depressed talking about all of us who can't and get anxious and feel tested, and we got it, and it's kind of, we all need to work on it. We all need to make it better, and we wish it wasn't what it is, and it's a little bit embarrassing. But what are the opportunities? If you were queen for the day and you could do something that could really have an impact, that could improve the public health using us being numerate, what would you do?
I'll be queen first. I'm on the left. But then we're moving to the right, don't forget. um, within the health exchanges, for example, I would have default options available for people so that instead of, if they don't go through and choose a health plan, there are default options available to them. I don't want to process all this information. It overwhelms me. Even highly educated people think that health insurance choices are just really difficult. I would have default options. It's politically going to be very difficult because which options are you going to choose? But something needs to be done in order to help. It's the idea of helping to relieve the cognitive effort. It's alleviating the responsibility that I think in some cases are going to be felt very strongly and very emotionally. Oh my God, I can't do this. I'm so stressed out by this choice. That's one of the things that I would want to do. Again, not particularly politically feasible. I would reduce how many options people are going to have available to them. I haven't seen the latest estimates on this through the health exchanges. It probably differs by state. But if you take as an example Medicare Part, what is it, Part D? Is that the prescription drug? If you take as an example Medicare Part D, I tried to do that for my father, and it was next to impossible. I ended up using some very quick cognitive shortcuts in order to get something that was good enough for him. I didn't try to maximize that choice. If I did, I would have been miserable over another 2 days of time. So those are some of the things that I would do, specific to the health exchanges.
Wow, I don't know if I can top that. That was queenly. No, I mean, having gone through the same process with my parent, trying to make those decisions as somebody, who should be able to do this, it was overwhelming. And at some point, I wasn't sure that it was going to make any difference. So I felt like, I could just bag it and close my eyes and do this. And so I think you're right. I think having fewer choices and the idea of a default makes total sense. Of course, if we would have had a single payer, that would have solved the problem. But
Even less politically feasible.
but the idea that it's so overwhelming that people will either just not do it and or ask somebody or just do hit the first one or something. I think it's really having the default is really good, or having somebody, and I don't know who that is, if that's volunteers or something, who can work, a place where you can go and say, we'll lay it out. These are the pros and cons for your situation. You have 2 kids, you have this, that, somebody's sick, and say, these are probably the first 2 choices. This one costs more, this one costs less, and, make it so that the decision is like going to the supermarket, and you either buy this brand or buy that brand.
The experience from Medicare Part D would suggest that a lot of people are going to end up choosing based on monthly premium costs. And that's probably fine for people who are relatively healthy within this ACA population. But for people who require a lot of health care, there's a decent chance that that kind of a strategy is going to lead them astray. And so I'd actually modify what I said before a little bit, which is to figure out different default options for people who differ in how much health care they need. But one of the things that would need to be worked on is how can you get from somebody how much health care they need? Because if you just ask somebody flat out, they may not really understand the question or how to answer it with respect to them and their family. And so figuring out how to appropriately ask that question in order to try to gear them into one default option versus another, I think would be important.
So just as a follow-up, and I'm saying this just to get it on the record, I think those answers, which are really sort of where the rubber meets the road when we try to figure out what to really do, help us reframe our own thinking from one that I find pretty depressing about what we can't do and how many of us struggle and all of that to what is it we're asking people to do, and how literate or health literate are those options for us, and how do we make what it is we need to be able to do doable. And it sort of reframes it in a way, I think, that allows us to move toward intervention in a way that puts an action agenda. So I really appreciate you all answering that. I know it kind of put you on the spot, but thank you.
Yeah, thank you. If I could reframe your reframe just a tiny bit, though. Part of the reason that I study why people can't do things is because it helps me to better understand how to make things better later. So it's through that understanding and a little bit of depression of understanding those mechanisms that underlie why people aren't adequately getting this, that we can start to focus a little more strategically on interventions that are going to help.
Thank you very much for the presentations. And I also wanted to follow up on Ruth's Queen for a Day question. Oh, Wilma Alvarado Little, I'm sorry. You touched on the health benefits exchange, the marketplace. And so I'm wondering how what you've presented and have responded to either, how do you see that folding into the role of the patient navigator, who's going to be put in the position to present the information and be the link, if you will, with the options that are being presented through the exchanges for those of us coming from states that submitted proposals. So how do you see that falling into the patient navigator role? Because some of the descriptions for the patient navigators, based on the communities in which the communities that have submitted their applications to participate, are looking a lot to have the navigators reflect the constituency of that community. But what resources or recommendations, if you were the queen for the day, would you include to empower that navigator to help address these issues?
Let me ask a stupid question if I can first. Is a navigator a person or is it a computer system?
It's a person. For the most part, at least I can speak for the state of New York.
Yeah, yeah. So difficult but interesting question. I think a lot of it is, what do I think a lot of it is? I think that the patient navigator should have skills, and tell me if I'm going astray on this, if you want to guide me a little bit more. I think the patient navigator should have skills in trying to understand what's important to the patient, because these different health insurance options are going to offer different kinds of benefits. And so to understand what's important to the patient in terms of monthly costs, or if something catastrophic happens, can you afford some big lump of money to spend? It's basically it comes back a lot of the time to what are the goals of the communication. So you can think about the health exchanges as communicating information about different health insurance packages. And the navigator is simply trying to help to uncover the goals of the patient within the goals of that health exchange. The navigator should understand some of this evidence basis for communication. People often think, and I don't know who's going to be hired to be navigators, but people often think, well, I just have to provide the information. And it's sort of that just the facts, ma'am, sort of approach. But just providing the information is often not enough, and that's particularly true for people who are less numerate, which is going to be a fairly large bulk of this population. And so understanding and maybe having some of the tools to be able to quickly display options in ways that the less numerate are more likely going to be able to understand and to consume that data and try to understand what it's going to mean for their lives. Those are some of the things that I would start to think about.
Hi, Steve Rush, Director of the Health Literacy Innovations Program at United Health Group. I'm coming at this from, pardon me? Oh, sorry, I just Yeah. Did we provide your health insurance? I'm looking at it from two ways. One is a clinician and one is a person who works within the insurance industry. And I wanted to thank you both for your presentations. One of the things that we've been looking at is the concept of health literacy. It's all about reading level and so forth and so on. And I've used some of your presentation and information to say, hey, health literacy is more than just reading. I was really interested in the concept of here's numeracy, but even a numerate person could be innumerate in certain crisis situations. And if you think about once a health plan acquires a consumer or a member, we don't have to worry about the acquiring anymore. We have to worry about ensuring or making sure that people are getting high quality, cost-effective care. And that involves a whole bunch of numeracy. And so then, while Ruth and others talked about how do we present this information to get people in, how do we present information to people once they're in so that they can make appropriate decisions about their health care?
And I think,
And excuse me. And the other piece to that is I'm really very much interested in the role of stress and having to make decisions. Okay, here's your health plan information or your benefit information happens in October. Make your decision and do it very quickly, kind of stuff.
yeah, I mean, I think I was going to say the same kind of thing about the, once you're in the plan, once that decision and going forward, and not only making your own health decisions, but but interacting and negotiating and advocating for yourself and your situation or your family members within the health plan world, and so, and being able to ask for things that, some health plan says you're not allowed to have for some
Right.
reason, and being able to argue back and ask the doctor or the health provider to support that decision. So I think it's ongoing.
Right.
Certainly the big decisions in the short run here are about getting into health plans, but that's only the beginning, and then everybody still has all of the same issues.
Right.
About managing their own health and dealing with insurance companies. And from my brother, who was a psychologist who worked with spinal cord injury patients, he used to say that it was so much easier dealing with the government than with private insurance companies for getting for his patients what they needed. And so thinking about, here was somebody working at a hospital who had a lot of clout, a big hospital. I mean, even that empowering, and I don't know that it's a literacy or a numeracy issue, but it's rather an empowerment issue, which relates.
Yeah. And certainly one of the comments was that numeracy to a certain extent has power. So then how do we provide information, numerical-based information to people when they're already in a health plan so that they can communicate better with their physicians and understand their treatment options and do a cost-benefit analysis?
There's a whole wealth of strategies. Your question is actually a huge one. It depends on what specific health situation the person finds themselves in, and again, what the goals of communication are within that particular health situation. What is the information that's most important for the person to understand and use?
Mhm.
Well, if you know information that's more important and less important, don't show the less important information.
Mhm.
That's sort of a very, very basic one.
Mhm.
You don't need to pack around important information, all this little context, and that often happens.
Yep.
So that's sort of a very, very basic one. But there's a whole wealth of strategies. It really depends on the situation. Some of the techniques many of the techniques have more to do with informing a consumer or a patient, helping them to better understand the numbers or to understand the meaning of the numbers sometimes. Other techniques are purely persuasive. If you think about graphic warning labels on cigarette packages, that's more of that is informing, but there's also a persuasive element to it. Physicians may want to persuade people to stop smoking, persuade people to lose weight. And there's information involved there as well, but there's sometimes you want a persuasive element too. Whatever the goal of the communication is, you choose different strategies, and there's a whole wealth of them. Some people today are going to be talking about a number of those different strategies. I outlined some of them, at least in the paper that we wrote. One of the things that I wanted to point out, though, because nobody has really brought this up today, is education of healthcare providers. So it's not just about the patient, it's about the people providing the information. Right. And there's not a lot of education of healthcare providers about how to best communicate with patients. I think that's an important, overlooked strategy for ultimately helping people be healthier.
Thank you.
We have 4 tents up, and I think we'll cut off the questions and go on to the next speaker after that. Let me just make a comment. Steve, your question and the responses in terms of the context reminded me that the ethical questions may lead to different solutions in different situations. Public policy could, for example, decide that there will be a limited number of offerings for insurance plans. And that would be a public policy decision that people may well decide is ethical. But when it comes down to the question of should I have this treatment or this treatment with a number of different types of side effects, it may be unethical to cut off some information. It may just mean that we have to spend more time helping the person understand. You could still have a nudge type of solution where there's a default, but you can't take away that information from an ethical point of view. So the situation will determine, in part, what is the appropriate solution or solutions that are possible. Bernie?
Bernard Dreyer, NYU School of Medicine, and representing the American Academy of Pediatrics. Tells you I'm a pediatrician. I have about 10 questions, but I'll limit them to 1 or 2 because of the time. I just want to start by saying I apologize to Dr. Ginsburg. I came late and didn't hear your presentation, but I did read your paper and hear your presentation. Dr. Peterson, was really phenomenal review of a topic that we for a long time have felt is such a critical part of health literacy. So I was looking at all the references to see what else I need to read. So my first question, or maybe only question, is in thinking of health communication, we usually think that between a doctor and a patient, or a health provider and a patient, we often say that the verbal aspect of the communication is probably the most important thing. And in narrative health literacy, we very much focus on how to communicate verbally. However, in thinking of numeracy, I guess it's a question I'm asking, not a comment. What's the relative importance of verbal versus written or graphic information? And what do we know about communicating mathematical information verbally?
There has not been a lot of research done on verbal communication of numeric information. Most of the research has been done with written. Some of the later speakers are actually going to speak to graphic presentation of data. I think Jessica Anker is. Brian Zickman-Fisher might be as well. I'm not positive. A little bit. Brian's going to do it a little bit. And so you'll get to hear some of the viewpoints and sort of a summary of the literature, I think, from them on graphic presentation. I have a lot of questions around that because healthcare providers usually communicate verbally. And people have a tough time parsing words, much less numbers. My suspicion is that numeric information would be better communicated in verbal form with a written backup for the most important information. That's my suspicion. I don't know of any studies, though, that have looked at this. And I'm not seeing anybody popping up over there to say anything different. It's actually an important research question, and I think it's one that the literature is overlooked in part because it's harder. It's harder to do that combination of verbal and written because it requires more intervention from an experimenter. But it's a really important question. I don't know the answer to it exactly other than my suspicion. I do know I've sat in and talked a lot with genetic counselors, and they often have written backup to the verbal words that they're saying. They find that important. I don't know if they've done any studies explicitly on that, but I suspect it is important.
Then just briefly, what are strategies to do when you're dealing with information that is really at the proficient level? So for example, your example of diabetics. I take care of children with diabetes and deal with both their parents and as they get older with them. Actually, sometimes the kids do better than their parents.
Yeah.
I deal with a low education population in general. So what are you supposed to do if you know people aren't proficient and yes, you're giving them tasks which you know somebody has to be proficient in? What are, I mean, I know it's sort of a dumb question in some ways, you try to simplify it, but is there research and understanding how to deal with that issue, or what are your thoughts on it perhaps?
Yeah, there likely are studies in diabetes that I don't know about, and I'm betting Darren may know about some of them, or maybe some of the other speakers within diabetes specifically. The kinds of things that I think about, making it simpler is a go-to always. Teaching things in terms of, okay, maybe they're not going to get the numbers, but they understand if my blood sugar level hits X level, I have a procedure. And so just having some very strong cutoff points that people have available to them in memory, if that's possible, or that they have on their equipment, to have some kind of a key there for them that they can always go back and look at in order, and that maybe has here's the cutoff level. If it's on this side, do this. If it's on that side, do that. To sort of, even if the person doesn't make it a habit, to help make it a habit through instruction. Those are the kind of things that I would think about. Understanding, helping them understand the meaning, the goodness or badness of various numbers is actually something that I think we've overlooked to some extent. People, if you give people a range and say, if it's in this range, you should do this, they may not understand that the number that's in front of them is actually in that range.
Right.
And so to help them understand better the numbers that are in a range and understand this range is good and that range is bad. Some of those kind of strategies I think are things that may help within these less numerate kinds of populations.
And just a quick one from the mathematics education perspective. We know that multiple representations help people understand math as they're learning math. And so I can't imagine that it wouldn't be helpful for many people, especially, people who are struggling with something new, a new situation, a new way of managing something, that the idea of multiple representations can only help. And as well, when they have, if most of the conversation or most of the interactions are verbal, they don't leave with stuff that they can re-examine and reflect on. And so if they can leave with tables and written information or graphical information that that gets reviewed while they're there, so you and they are confident that they have some understanding of what they're taking with them, has to help because it adds time to the learning rather than just the few minutes or hour that they're with the practitioner.
And Bernard, probably the best people to ask about this are your patients and how they've managed to cope, because people who have deficits develop elaborate coping strategies that we don't imagine. So when I was out in Iowa and the new readers of Iowa were meeting with the Health Literacy Collaborative, one of the patients in the system said he was a truck driver and didn't know how to read maps and wasn't really good on directions and stuff. And the way he managed to do that for a while would be he would be able to get himself on the interstate to around where he was headed, stop off at a diner, chat with people, get directions, put left at the light on stickies and put that on his windshield. I never would have thought that would be a good way to cope with not knowing how to read a map before GPS talked to you. So, I think that actually some of the people who we're trying to help have figured out strategies that we can learn from them and then teach to others.
We still have time? Okay, good. In both of your talks, you talked about research that shows how increasing a person's interest, engagement, involvement, and their eventual numeracy capability could be partially based on better tailored materials to them and other strategic interventions. And apparently there is a good deal of research in that area, which you've helped me understand. But both of you also mentioned that it's also possible where, and these are my words, not yours, an opportunistic contextual transformation occurs based on your employment, based on your role. For example, we just heard a discussion about role and how it impacts, okay, patients' knowledge and interest and involvement, okay. There's even more dramatic examples. All of us around the room are familiar with a website called Patients Like Me, where you see patients with no medical training whatsoever who develop an impressive knowledge of medicine. And if you interview or talk to all those persons, the first thing they'll tell you is, I never had any interest in math. I never had any interest in science. I never had any interest in medicine. But my opportunistic role transformation, what I'm interested in is how much research literature do we have about the second transformation and ways to, and when that transformation begins to occur, to take advantage of that opportunity.
I don't know of any research that's explicitly on that transformation process. What I know is research that goes around it, that's related to it. So for example, we've done some studies looking at people's ability to choose high quality hospitals given a variety of information. And one of the things that you find, people are given quality of care indicators about those hospitals. And one of the things you find is that numeracy matters. People who are more numerate are more likely to choose higher quality health, hospitals. Independent of that, but still a significant effect, people who are more health literate, according to more sort of reading levels, they're also more likely to choose high quality hospitals. Interestingly, women tend to be less numerate, but women actually are more likely than men to choose high quality hospitals, and likely because of experience. Women tend to have more experience within health settings. They're more likely to take care of their family's health concerns than men are. And so you see some of these additional skills that have developed in females compared to males. There's a lot of research that's been done at this point on patient activation, which is related to what you're talking about here. If you know the research by Judy Hibbard and some of her colleagues. Yeah, so you're kind of getting, and I don't know, that research is the closest that I can think of that tries to get at that transformation process. They've been trying to manipulate people's activation, getting them from one level of activation to another. I don't know if they've been trying to understand what gets people, what are the mechanisms there? That I'm not sure if they've been doing. But they've, yeah, I didn't think so. And it's not the kind of thing she would normally do. But we got it. Okay.
Thank you. Again, thank you, Ellen and Lynda, for the presentations and for the wonderful questions and comments that have come from the roundtable members. We obviously have run out of time for further discussion at this point. So I'd like to introduce